This is the the health begins where we live, work, learn, and play panel. And we'll start out with Brenda Battle. Ms. Battle joined Barnes-Jewish Hospital as a director of the Center for Diversity and Cultural Competence in August 2006. In her role, Ms. Battle oversees programs to eliminate health disparities for diverse populations and to promote diversity and cultural competence within Barnes-Jewish Hospital and the Washington University School of Medicine. Prior to joining Barnes-Jewish Hospital, Ms. Battle served as Vice President, Government and Community Affairs for Medical Transportation Management, Inc., a national contractor for non-emergent transportation benefits for Medicaid beneficiaries. Ms. Battle has more than 29 years of healthcare-related experience, beginning with a nursing career in 1981. Ms. Battle is a member of the Board of Directors for the Missouri Foundation for Health, is Vice Chair of the Board of Directors for the National Conference for Community and Justice in St. Louis, and the Board of Directors of the American Heart Association. She also serves on several advisory boards. Help me welcome Ms. Battle.
Okay, I'll just advance there. Okay, first of all, I want to thank you guys for hanging in there this afternoon for this panel. And I really appreciate being able to follow Dr. Sullivan, because what he said, hopefully as I go through my presentation, will demonstrate how a lot of those things are being played out in an institution in St. Louis at Barnes-Jewish Hospital. And also, Stan, thanks for changing the name of it, because this morning I was going, okay, how am I going to fit what we do? And, because social determinants can somewhat be a difficult conversation for those of us in the hospital, because we have to figure out how within a hospital setting to use the work that we do to impact the determinants of health that our patient populations deal with in the community. And we've got a big job to do that in the community. So this is perfect. That change of name helped me to, where we are, where we work, and that sort of thing. So hopefully we can help fit that where it needs to fit. So we all know what social determinants of health means. So I'm not going to define that, but I think it's important to say that within the hospital systems, it's really critically important that we get the issue of social determinants of health in the C-suites, where the leaders of our organizations are working, because we get, we engage around talking about quality and safety and all of these things, and sometimes we miss the connection of how difficult it is to achieve those healthcare outcomes that we want to achieve if we don't keep in our mind the issue of social determinants of health, and certainly health equity. That we see that in our work every day in the hospital, but we don't always consider social determinants of health and how difficult it is to get to that end goal of achieving healthcare, the safety and quality outcomes we want, if we don't understand first social determinants of health. So we have to keep that in front of our C-suite. And in our hospital, we're a safety net hospital in the city of St. Louis. We have over 80, almost 90,000 visits to our ED. And, we're a 1,200-bed hospital where our patient population is a split, 60% Caucasian, 40% everything else. With the majority of that being African American, but about 5% everything else, and a 5% population who doesn't speak English as their primary language. So we have to consider the issue of social determinants of health within our environment as we try to get to this end goal of these good health outcomes and delivering good quality and safety for our patient population. So, these rankings you guys have seen, the Missouri rankings, and so as we help our organizational executives and leaders and presidents and board understand how critically important it is for us to understand our impact or our ability to influence better outcomes for our patients, it's important that they know that the state that we live in has a problem. And I found it interesting to realize how unattached sometimes folks in the hospital, how they are from these healthcare outcomes that we face in our state. And so you guys all know this. You know the death rate, the issues we're dealing with, the death rates. And so the reason I thought this was important for us is because, we have that population split of 60-40. And when it comes to social economic status, we have the flip in terms of what our payer mix is. So about 60% of our payer mix is Medicare, Medicaid, and uninsured, and the other 40% are insurance payers, Blue Cross Blue Shield, and all these other folks. This was an important slide, I thought, that was important to us, because when we saw this data and recognized that those 80, 90,000 admissions to our ED are people that come in with these diagnoses. And realizing that if we don't do something to address these diagnoses, particularly those things that come March 2012 will no longer be reimbursed by Medicare. To start with Medicare, we believe anything that happens with Medicare transcends and gets moved to Medicaid and of course to private insurance, that we are not going to be this accountable care organization that we are intending to be for our in our community if we don't address these particular issues. And I highlighted those red spots because when I brought this before our folks in the C-suite, I wanted them to realize that while this is Missouri data, when you look at our data looks exactly like this. And so we need to address those issues. That's your president, your vice president, your executive staff in your organization. I apologize for illiteracy. Thank you for catching me on that. Appreciate that. And the other thing that we are, have to be responsible to is the Joint Commission. And the Joint Commission is telling us that when they look across the nation and in our hospital, where we're having the biggest issues is we're having issues around communicating effectively to our patients and communicating to each other in handoffs, handing off information to each other from physician to nurse, nurse to nurse, physician to physician, that's going to impact the outcomes of our patient population. So, and again, we talked a lot about health literacy, how important it is to consider not just the literacy level of our patient population that are not English proficient or don't speak English as their primary language, but those folks who speak English and how we talk to them and what we give them in their hand to take home with them. We did some readability scale checks against some of the information that we were giving to our patient population on breast cancer, colon cancer, and prostate cancer. We ran it through the scale. Well, it was the 18th grade. 18th grade. You guys figured that out. Well, so we have to produce documents that our patient population actually can understand. So our program around addressing health disparities is intended to be a comprehensive program that forces us to tap into all of these issues so that the end result is that we are delivering good patient quality care and our patients have safe care delivered to them, and that we're helping them as they transition out of our environment into the environment, in the community where they're receiving care. So we have 5 basic domains that we're focusing our work around. And the first is workforce diversity. And so as we look at workforce diversity, we're looking at, yes, attracting the best diverse talent to our organization, but we're also looking down inside our organization to determine how we could develop people from within our organization to be promoted to these positions that we need, and we need them in. So we know that we're not going to get, if there's 9% of the population in the country that's nurses and 7% that are dentists and 9% from medicine, and these small percentages in terms of people of color, it's going to be awful hard for us to be the only ones where we're all grabbing at those folks trying to get them. So we have to develop from within our organization, and we have to create opportunities for people to get educational benefits, keep our educational benefits intact, move our people, train our managers to help move our people into these educational opportunities so we can develop our pipeline from within. And we have to reach out into the community and start at the 5th grade levels as we're trying to develop pipelines of people interested in pursuing healthcare careers. So all these things around workforce diversity have to be at play at the same time in order for us to affect an outcome that will be related to workforce diversity. Training and education, critically important. Education on cultural competence. We have to not only learn how to speak in plain language to our patients, but we have to make sure that what we speak to them is meaningful to them according to their culture, what is important to them based upon what their cultural values and beliefs are. So we do an extensive training on cultural competence in our organization, and we start with a program that trains trainers, 18 hours of training in the first year, 16 hours of training in the second year, and this is to develop trainers who are positioned within their divisions and areas who will train their colleagues on these issues related to cultural competence and issues related to health literacy so that we can have a team of folks on the ground, highly trained, highly educated, prepared to help us deliver this knowledge that is culturally based. The patient-centered communication has to do not only, as I said earlier, with health literacy or patients that speak English as a second language, but also the issues around, we've lumped that with our health literacy under that area as well. And then the community engagement. How do we work with communities that are marginalized, work with communities where education, they don't have access to the amount of education that they need in plain language. So we have that as a focus of one of our domains, is how do we get into the community and actually work with those individuals from limited English proficient populations as well as all of our populations, where we can educate them at the level, at the places where they are typically getting this type of information. And lastly, focusing our research and interventions and strategies on identifying how we can close the gap in disparities, how we can actually use nursing research at the bedside to help impact the knowledge around how we can affect patients both culturally appropriately and from a health literate perspective. And so we use the IOM's domains for quality of safety, effectiveness, patient-centeredness, timely and efficient and equitable care. We use those domains, but what we've begun to do with that is, as we look across our population at stratify our data by race, ethnicity, and language, we're taking these domains and stratifying the quality and safety indicators and all the other things that we measure, our core measures, stratified by those demographics, so that as we consider this is the domain we've decided to follow. This is what the United Health Consortium is using. This is what the IOM has recommended. So as we look at our data, we're stratifying our data this way so that we can see where there are gaps, identify them, and then develop the strategies and interventions to address them based upon what we see. The hardest part is prioritizing. And lastly, this is just, the whole cultural competence framework is about understanding cultures, but understanding ourselves. What is that intrinsic bias that we may actually participate in as we're working with patients and making decisions around patients? What is that? And then what are the interventions that we can actually teach ourselves? What are the strategies we can actually teach our staff so that they can communicate better with our patients, they can assess our patients appropriately from a cultural perspective? And then at the very top ladder of the rung of this ladder, what are those organizational systemic issues that are happening within our system that are either enhancing or inhibiting cultural competence? So what are some of these policies that are in place that totally go against what you're trying to do with cultural competence? And we're literally taking the policies, looking at all of our policies and saying, where do these fit? Are there cultural competency principles in these policies? Do these work? And then the next phase from that is rolling out to our staff these new policies, these change policies, these policies that encompass cultural competency and health literacy in them, so that we can start measuring our staff against those as behaviors and standards and norms and practices within our organization. So these are just a few of the things we're doing. I'm on 1 minute, very quickly. We have a health equity committee, which we're really proud. We formed this year, that's reporting to our medical executive committee. It's a part of our patient safety and quality committee. And that committee has a responsibility of really looking at this data, really drilling down into this data and identifying where there are gaps and what we need to do to fix it. We're just happy to be positioned in an organization where we can actually take some of those principles that Dr. Sullivan talked about today and put them to work. Is my minute up?